Hello my dear friends, in this video I would like to give you a few tips on how to perform small pupil phaco with a hard cataract and how you can do it with relative amount of confidence. These tips will help you to shrug off your fears, and all it requires is that you take it one step at a time. Let's move on to the case now. This case involves an elderly gentleman of 85 years who presented with a grade 3 nuclear sclerotic cataract and a maximum pupillary dilatation of 4.5 millimeters. I did the procedure under topical anesthesia with subconjunctival augmentation. The anterior chamber is extremely shallow. You can see that I'm tagging on a bit of iris while entering the eye. Always instill intracameral lignocaine. This will help to anesthetize the intraocular contents better, and always make it a point to stain the anterior capsule with trypan blue in all cases of small pupils and hard cataracts and all challenging cases. The clear corneal incision has to be fashioned correctly. You cannot have a premature entry. The wound seal should be good. Wash off the trypan blue before you fill the anterior chamber with viscoelastic, because this will give you a much better fill of the viscoelastic and a much crisper view. Now the small pupil has to be handled with the help of a Gupta ring. In spite of the fact that I have presented many videos on how to load it, let me tell you a simple way of orienting the Gupta ring. While orienting it, choose the scroll so that the left limb is at a lower plane and the right limb is at a higher plane. This is how you have to choose the scrolls. Every alternating scroll will be different with respect to orientation of the limbs. In order to insert the Gupta ring, just hold on to one of the scrolls, flex the ring and push it into the nozzle. This is the easiest way of getting it into the nozzle. Now once you have oriented the Gupta ring in the correct manner and you have loaded it correctly, then you don't have to worry about which limb is going to lie above the iris plane and which limb is going beneath the iris plane. So you see, I am injecting the Gupta ring inside and I am aiming not at 6 o'clock position but closer towards the 7 o'clock position, and the minute the scroll engages, now I am only focusing on the limbs. The right limb will go above the iris, the left limb keep it below the iris, and once you do that, the scrolls will automatically engage. This is the beauty of the procedure. Then the final trailing loop can be tucked into place from the side port, and even while tucking this scroll, just focus on getting the limb underneath the iris. If you do that, the scroll will automatically engage. So you can use the limbs of the Gupta ring, place it either beneath or in front of the iris in order to engage the scrolls. Now you see that I have a great orientation of the Gupta ring so that the limbs underneath the iris are adjacent the incision site and will not interfere with my instrumentation. While performing Capsulorhexis, because of the extremely shallow chamber, I found it a little difficult and I was getting multiple tears in the anterior capsule. However, I persisted and I got a successfully completed Capsulorhexis. You see, at this point I inadvertently tore the anterior capsule, but I included that in the final rhexis. So now I have a continuous curvilinear tear of the anterior capsule, even though it is not extremely round, or it also tends to be a little large. Cortical cleavage hydrodissection should be done very cautiously. Inject very small amount of BSS, and that is usually enough to accomplish the cortical cleavage hydrodissection. It is a good idea to check for rotation before you start the phacoemulsification, because if a hard cataract fails to rotate and you give too much of pressure while trying to rotate it, you can create zonular dialysis. Now the anterior chamber is being filled with a viscoat which contains chondroitin sulfate and sodium hyaluronate. This is to maintain the space as well as to protect the corneal endothelium. Now let's observe how the direct phaco chop goes in this procedure. So bevel down position, instant occlusion, driving the phaco tip deep into the substance of the nucleus. Using the sharp chopper, I'm initiating the crack first. I'm not going to attempt to create a through and through chop. Just initiate the crack. Then bury deeper inside the piece. Take the second instrument deep down and you can separate this huge nucleus completely into two halves. Now I create another crack. Initiate the crack, bury into the nucleus piece, take the second instrument deep into the crack, and with gentle sidewards movement, a lateral separation can be accomplished and the pieces are separated. Let's watch this again. Initiate the crack. So you're not trying to create a through and through separation with the crack. The first chop is to just initiate the crack. Then you bury deeper, get a good hold, take the second instrument deep down, and then you can complete the separation. This is the best way to do it. It is safe and it does not endanger the posterior capsule in any way, neither does it give undue stress to the sonules. The lateral separation is also kept to a minimum. See the way it is done. The first chop is just to initiate or open up a crack in the nucleus. Then you hold the crack portion of the nucleus firmly, take the second instrument deep down into the crack, and then finally create the separation. Now I have broken this down into multiple pieces, more than 6 pieces, and I exchanged my sharp tip chopper with a Sinskey hook, and each of the small fragments are then being emulsified in the central safe zone. The smaller the pieces, the more control you have in fragment mobilization and subsequent emulsification and removal, and it is also safer to the endothelium because you do not have stray pieces hitting against the corneal endothelium. Now when you have viscoat in the anterior chamber, small pieces tend to get stuck to the viscoat and to the endothelium. It can sometimes happen. Do not give phaco close to the endothelium. Use vacuum to pull these pieces away from the endothelium, bring it to the central area and then emulsify it. Now the settings in this particular case is I'm using a phaco power of 40% and a multiburst mode with a burst duration of 30 milliseconds and a duty cycle of 70%. Also remember that you always have to top up with the dispersive viscoelastic in order to maintain the space and protect the endothelium. Viscoat is being now injected into the anterior chamber. The nucleus emulsification now proceeds. More than half the nucleus has been removed. The fragments have been clearly and nicely separated. It is emulsified and removed from within the eye. You can build up your confidence by just learning how to create the crack, how to effect the lateral separation, how to make multiple small fragments, and how to make multiple small pieces. Now once you achieve this, the fragment removal can be done in a safe environment. The fragment removal is almost over. Now using the phaco probe itself, I'm able to use vacuum and pull up the epinucleus, which is removed. The good cortical cleavage hydrodissection ensures that you have very little cortex left at the end of the procedure. At this point, I use simple hydroxypropyl methyl cellulose and not dispersive viscoelastic, simply because it's more difficult to remove the dispersive viscoelastic, and secondly because the procedures which I'm going to do subsequently will not damage the endothelium in any fashion. Like I said in the beginning, you can actually perform a hard cataract phacoemulsification even though the pupil is small with a great level of confidence. You don't really have to worry too much as long as you take it one step at a time. The minute you dilate the pupil with a pupil dilating device, the threat of a small pupil does not exist. And if you learn how to create the fragment separation in the CHOP, the challenge of a hard cataract also becomes greatly lessened. The intraocular lens is now being injected. This is an aqueous adapt intraocular lens. So this has got a plate haptic design. The viscoelastic is then removed from behind the intraocular lens. This is an important step because we don't want to leave behind residual viscoelastic within the capsular bag. In this case, there is no threat for a post-op capsular block syndrome because of the large size rhexis. The penultimate step, of course, is to remove the Gupta ring. So fill the chamber with viscoelastic. The ring is quite easy to remove. You'll have to engage close to the scrolls and then lift it out of the pupillary plane. So you have to go close to the scrolls. Do not try to disengage by holding on to the limbs of the Gupta ring, but you have to hold close to the scroll and you have to disengage it from the pupillary margin. Disengage all the 4 scrolls first before attempting to remove it. So once the ring is free floating in the anterior chamber, further viscoelastic is injected, and using an intraocular forceps and using a Sinskey hook as a guide to present the scroll to the intraocular forceps, it's held and removed from the eye. There are small areas of hemorrhages that are seen near the pupillary margin. This occurred while attempting to disengage the scrolls from the pupillary edge because this is a small friable iris. Remember that it's important to aspirate all the heme and all the hemorrhage and blood from within the anterior chamber. Leaving behind residual hemorrhage will create a fibrinous reaction in the anterior chamber in the post-op period. The patient will have much more anterior chamber cells and flare. So the procedure is now completed and it was done with a relative amount of ease. I hope this lecture helps you to tackle your next case of small pupil, hard cataract, phacoemulsification, and I hope you can do it with reasonable amount of confidence. Thank you for your attention.